Should you titrate antipsychotics slowly or just get it over with and push the dose up? The answer depends on which one you're using. Plus, a research update on pramipexole in treatment-resistant depression. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a Psych MP and a dedicated reader of every issue.
Two antipsychotics that have always confused me are quetiapine and Ziprasidone. These two cause a lot of problems when I'm starting them: sedation, dizziness, hypotension. So the question is, should I raise them slowly, or does that just drag out the pain, like slowly going into the cold water of the pool 1 inch at a time? The answer is different for each of them. With Ziprasidone, Giadon, you want to titrate rapidly. Paradoxically, patients tend to tolerate Ziprasidone better in the higher dose range. Several studies found that patients stuck with Ziprasidone longer if they started it at a high dose, like 120 to 160 milligrams, than if they started it at a low dose, like 40 to 80. On a similar note, many clinicians find it easier to tolerate Ziprasidone if they just raise it up quickly, and that strategy has also proven successful in clinical trials. Here's how to titrate Ziprasidone in mania and schizophrenia. Start with 40 milligrams twice daily with a full meal, and raise the titrate to the treating dose of 120 to 160 milligrams by the third day of treatment. So basically, get it up there to the full dose within 3 days. Quetiapine, that's a different story. Faster titration is less tolerable here. It brings higher risks of sedation, dizziness, agitation, and other side effects. That conclusion is from a 2019 analysis of 18 studies that compared the standard titration for quetiapine, the one in the PDR, to more rapid approaches. So with quetiapine, stick with the titration schedule in the PDR. But keep in mind that the PDR allows faster titration when you're titrating quetiapine XR, because the XR smooths out the peak levels that cause dizziness and orthostasis. That's why the PDR recommends slower titration with the instant release. For example, in schizophrenia, the PDR says to start quetiapine at 50 milligrams per night, that's 50, when using instant release, but you can start at 300 milligrams per night with the extended release. And, head-to-head comparisons of instant and XR quetiapine in the same dose range also find that the XR is better tolerated during the titration.
XR is better tolerated in titration, but what about once they're on it?
That's a good question. Early on when the drug company was trying to shift everyone to the patented XR quetiapine, the reps would pass around this study that suggested XR caused less fatigue than instant release. On the face, that really doesn't make any sense. Why should something that lingers longer cause less fatigue? But if you look closely at that study, it was not a fair comparison. They were comparing instant release twice a day versus XR once at night. And of course, you're going to be a lot more tired if you take an instant release quetiapine when you wake up. Well, the bottom line, it's all with quetiapine, a lot of confusion. And you need to know this stuff though, because this is a med that you really got to fine tune with patients. So the bottom line is that the main advantage of the XR version is there's less hypotension and falls on it. And this gets to be a problem, particularly when you're dosing quetiapine beyond 300 milligrams. So what I do in practice is I use the XR if the patient is older, if they're frail, if they're prone to hypotension, or if we're going to 400 or above in the dose. Otherwise, I tend to use the instant release quetiapine, but based on this research, I might be inclined to use the XR to titrate, since so many patients reject quetiapine during the titration.
But what about if they are just using 150 to 300 milligram at night, the kind of dose we use for depression?
There the answer is not what the drug reps would have hoped for. Morning fatigue is higher with quetiapine XR than instant release when you're in that range and even when you're at 300 milligrams at night. And, this is what you'd expect. If you're going to give someone a drug that lasts longer, you'd expect to have morning fatigue with it. So, bottom line, if your patient has titrated successfully with quetiapine and they keep complaining of that morning fatigue, try switching to the instant release.
Quetiapine is a complicated drug, so let's do a bottom line. Start quetiapine as XR to improve tolerability. If you're aiming for a high dose, like in mania or schizophrenia, or your patient is older and prone to falls, stick with the XR. If you're aiming for 150 to 300 milligrams, you might consider switching to instant release after the titration. And why would you want to do that? If your patient has daytime fatigue, or if they can't tolerate the onerous directions of the XR, they need to take it an hour away from food and alcohol to prevent the dose from breaking down all at once, but 12 hours before they plan to wake up. Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. Which statement about ghost pills is true? A. They occur with most extended release formulations. B. The medication is still completely released, even when they are excreted in the stool. C. Their appearance in the stool is a sign of incomplete medication release. D. Their appearance in the stool is a sign of delayed medication release. If you've listened long enough, you've probably figured out the point of this podcast series. We don't want to scare patients with false starts on meds, but side effects are not the only things that frighten patients. There's also ghost pills. Here's how it happens. You switched your patient from Adderall to Concerta, and they call to complain that it isn't working. Once more, they know why. They can see the entire undigested capsule in their stool after they pass a bowel movement. What they are really seeing is a ghost pill. These are normal and expected with extended-release capsules that use an osmotic delivery system, a kind of internal pump that squeezes out the medicine but leaves the capsule intact. Reassure your patient that they are still getting all the medicine, and a little advance warning helps. Here are the psych meds that leave those ghostly trails: Concerta, carbamazepine XR, paliperidone, Invega, and venlafaxine XR tablets, but not venlafaxine ER. Now for our research update. Pramipexole augmentation for the acute phase of treatment-resistant unipolar depression, a placebo-controlled, double-blind, randomized trial in the UK by Michael Browning and colleagues from Lancet Psychiatry.
Pramipexole is a dopamine D3 agonist approved in Parkinson's disease and restless leg syndrome. It is one of many novel meds for depression that has enough support to recommend it when nothing else works, but not enough to rank it in any practice guidelines. This study changes that. It is a large, with 150 patients, multi-center, double-blind, placebo-controlled, and it is long. They tested the drug against placebo for nearly a year, 48 weeks. They also tested pramipexole in true treatment resistance, not just in patients who failed one antidepressant, which is what 70% of augmentation trials do. These patients had to fail at least 2 antidepressants. On average, they failed 3 to 4 trials. Here's the most important part. Pramipexole worked on all the primary and secondary outcomes with a large effect size, 0.9. By comparison, most other augmentation strategies, lithium, antipsychotics, they have only a small effect size. So 0.9 is closer to what we see with ketamine. But unlike ketamine, in this trial, pramipexole kept working. The benefits did not diminish much over the 1-year trial, something we can't say for antipsychotics, which failed by month 6 in most of the industry-sponsored trials that tried to test them long-term. The dose in this pramipexole trial that they marched up to was 2.5 milligrams, and they titrated it slowly, starting at 0.125 milligrams and raising it every few days. Other trials aimed for lower doses, which also work, 1.5 milligrams at night. But there was a hint in some studies that patients with higher degrees of treatment resistance respond better to pramipexole in the higher dose range, like 2 to 3 milligrams. That's why they went a little higher here. Now, the main limitation in this study was that 70% of the patients correctly guessed whether they got the med or the placebo, possibly because it worked so well or maybe because it was sedating. But that is a limitation of most trials, particularly antipsychotics and ketamine, and it's also a strength of this study that they actually asked patients which one they got. Most studies do not ask patients to guess which medication they got. The study also answers a nagging question about pramipexole. Does this dopamine agonist make people gamble compulsively? We know that's a risk with other D3 agonists like aripiprazole, brexpiprazole, and cariprazine. But strangely, there have been no reports of compulsive gambling or other hedonic excesses in the 600 patients with mood disorders who were treated with pramipexole in earlier trials. That is very strange indeed, because when pramipexole is used in Parkinson's disease, the risk of hedonic dysregulation is 15%. So what is going on there? Well, this study very carefully assessed for hedonic dysregulation, which includes not just gambling, but other hedonic problems like compulsive masturbation at work. Because if you don't ask, you're not going to know. And here's what they found. 3% of the patients had hedonic dysregulation. In my own practice, the rate is closer to 1%, but I use lower doses like 1.5, while this study used 2.5, and I have found that the hedonic dysregulation improves when I lower the dose. Hallucinations are also dose-dependent as a risk on pramipexole, as it can nudge the D2 receptor while it's working on D3. In this study, only one patient complained of hallucinations, and they did so after starting a steroid, so it wasn't sure that pramipexole was causative. The bottom line, our available augmentation strategies for treatment-resistant depression are high on risks and low on long-term benefits. Pramipexole brings a better ratio there. It has no weight gain, no sexual dysfunction, and with long-term use, it doesn't have any major medical risks, although it can cause low blood pressure when you're starting it. We're going to have more details on how to use it in our upcoming Carlat textbook on difficult-to-treat depression. Look for it this fall.
Looking for more ways to bring psychotherapy into the medication visit? Check out the September issue of the Carlat Psychiatry Report, where Drew Ramsey shares his 9 tenets of mental fitness. Start your subscription with the promo code podcast to get $30 off.